Hello, my dear future doctors. How are you? I'm fine, thank you. I hope you're doing fine too. Uh, this is how we're equipped for nowadays. I'm just coming right straight from emergency department, so we are wearing our protections because every patient is considered to be thought infected with the COVID-19, so that is how we're protecting ourselves, and that is how I'm keeping my mask because we're short in masks. We have a shortage in masks, so we're saving, reserving what we have. So let's not talk about coronavirus anymore. Let's just concentrate on our studies. As far as you know, tomorrow I'm not gonna be able to do online lecture with you because I'm on my nighttime shift, as you see, and tomorrow morning I'm gonna be on a surgery. So that is why I'm recording this video for you. I hope you it's gonna help you with your studies. So today's topic is gonna be we are dividing week 6 topic into two. It is general anesthetics. We're gonna talk about general anesthesia, inducing and the recovery of anesthesia. We're gonna talk about inhalatory anesthetics, and as well intravenous anesthetics and some agents separately. And for the next lecture that we're gonna have on Wednesday, we're gonna talk about skeletal muscle relaxants. Okay, so I hope you are good with my speed of talking. So I'm gonna hang on today's topic. So don't ask me how I printed it to be visible in the selfie camera. Okay, let's not waste any more time and just go directly to the topic. As I said before, I wanted to talk about general anesthetics. These are the drugs which produce irreversible loss of sensation, all sensation, especially pain, and as well consciousness. So these drugs produce loss of sensation and consciousness, which is irreversible. So the cardinal features of general anesthesia are the following. First, as we said, loss of all sensation, and mainly, most importantly, especially pain. Then inducing sleep or unconsciousness, and as well inducing amnesia, or which is equally important as the unconsciousness, because the patient shouldn't remember the painful experience, which is the surgery. It's a traumatic experience for an individual. And then next feature will be immobility, which is equally important for the surgeon, and the muscle relaxation is among mobility. And last will be absence of all the reflexes. How could you imagine the patient laying under the scalpel of the surgeon and with the reflexes? So these are the important features that general anesthetics should have. So, and the modern practice, we've got balanced anesthesia, which involves as gaseous or vapor anesthetics, as well as intravenous. So this anesthesia should be achieved by using combination of drugs. Each one has a specific purpose. Some of them induce anesthesia, some induce quick recovery, and so on. Now let's talk about the mechanism of the general anesthesia. It is not precisely known, to be honest with you. There are very wide variety of chemical agents produce general anesthesia. Therefore, not all of them are used for as a general anesthetics. The important feature that general anesthetic should have is anesthetic potency, which is measured by the coefficient called MAC or MAC. It is a minimal alveolar concentration, and it's the lowest concentration of the anesthetic in the pulmonary alveoli needed to produce immobility as a response to a painful stimuli, for example, the surgical incision, in 50% of individuals. So, is everything clear with this? I hope it is. It is accepted as the valid measure of potency. So MAC is accepted as the measure of the potency for the certain general anesthetics. So I will just go to the stages of anesthesia, which I think are important when talking about anesthetics. So this general anesthetics cause an irregularly descending depression of the CNS. For example, the higher functions are lost first, consciousness and the progressively lower areas of the brain are involved. But it's different, totally different while talking about spinal cord. The lower segments are affected earlier than the higher segments. So the vital centers located in the medulla are paralyzed at the last one, as the depth of the anesthesia increases. So now let's talk about the stages of the anesthesia. We've got 4 stages. Let's start with the first one, obviously. Stage 1, it's called analgesia. It is the stage from the beginning of anesthetic inhalation to loss of consciousness. So until the patient loses consciousness, we've got the stage of analgesia. So pain is progressively abolished, as you understand. It's because it's analgesic stage, and some minor procedures can be performed, but difficult surgeries are not, of course. And this stage is really difficult to maintain as well. So this was the first stage from the beginning of inhalation anesthetics till the loss of consciousness. Now, logically, the second stage, which is called stage of delirium, is from loss of consciousness. We continue as we start. From the loss of consciousness to the beginning of regular respiration. So it's includes excitement, struggling, breath holding, sometimes jerky breathing, and sometimes sympathetic, most of the time, sympathetic stimulation. So in this stage, no procedure can be carried out, which is a dangerous stage and should be avoided and shortened as possible. So the third stage, what will be? So we have already lost consciousness. So the third stage is our desired or wanted stage. It's a surgical anesthesia in which most of the surgeries are performed. It is from onset of regular respiration to cessation of spontaneous breathing. So spontaneous breathing ceases, it means the patient is wholly anesthetized. So this stage is divided into 4 planes, which I'm not going deep into. Just gonna mention that plane 1 and 2 is obviously best for carrying out the surgeries. And lastly, the stage 4, which will be the logical end of this depression. It is medullary paralysis, from cessation of the breathing to failure of circulation and death. Obviously, it is never attempted to achieve. So the fourth stage we are not gonna achieve by the anesthesia. So this was all about the stages. Now let's talk about the observations that modern anesthetics has to depend on. So, for example, if eyelashes reflex is present and the patient is making swallowing movements, so it means that we've got stage 2. It's not still the stage 2, it's starting at the beginning of the stage 2. Stage 2 has not been reached yet. Another observation is that incision of the skin causes reflex increase in the respiration, or air respiratory rate, RR, and the blood pressure raise and other effects. An insertion of the endotracheal tube is resisted and induced coughing and sometimes vomiting and even the spasm of the larynx, and tears appear in the eyes of the patient. And anesthesia is light. Passive inflation of the lungs is resisted. It means that anesthesia is light. And also, fall in the blood pressure, cardiac and respiratory depression are the signs of deep anesthesia and should be cautiously monitored and maintained and avoided as well. So, now I'd like to talk with a few words about the pharmacokinetics of inhalation anesthetics before going deeper with the inhalational anesthetics. So inhalational anesthetics are gases or vapors that diffuse rapidly across pulmonary alveoli and also across the tissue barriers as well. The depth of anesthesia depends on the potency of this agent, and the potency is measured with the MAC, as we said before. It is MAC, or minimal alveolar concentration, and as well PP. You're gonna meet it in your book. It means partial pressure. So partial pressure in the brain. So anesthetics should cross blood-brain barrier in order to achieve the surgical state. So while induction and recovery depend on the rate of change, partial pressure in the brain, it means this MAC and PP should be controlled. So you're gonna pharmacokinetics, you're gonna read it in the book I will give you. This is the chapter 8 in your book. If you want, I will then send you exact pages. So now with a few words, I would like to talk with you about the factors that affect the partial pressure of the anesthetic. The first factor is partial pressure of anesthetic in the inspired gas. So the higher the inspired tension, more anesthetic will be transferred to the blood. So, and the easier will be induction. So it is logical. Higher inspired tension, higher anesthetic, more anesthetic goes to the tissues and transferring through the blood and causes the rapid induction. The second factor will be pulmonary ventilation. What does it mean? It is the delivery of the general anesthetic to the alveoli. So hyperventilation will bring more anesthetic per minute and quicken the induction. Okay, it is pretty clear, I guess. And the third factor that affects the partial pressure in the brain is alveolar exchange. So general anesthetic diffuse freely across the alveoli, but if alveolar ventilation perfusion are mismatched. So, for example, it occurs when the patient has emphysema or chronic lung disease. So this mismatch between ventilation and perfusion causes the equilibrium between alveolar and blood to be delayed. So induction also will be delayed, as well as recovery. Both of them, reduction, induction, and recovery, will be slowed down. Another factor is going to be solubility of anesthetic in the blood. How you understand? this is, as you understand, solubility of the general anesthetic. It's most important property determining induction and recovery as well. So large amount of anesthetic that is highly soluble in the blood or dissolved before its partial pressure is raised. So the rise as well as the fall of the partial pressure in the blood, consequently induction as well and the recovery are slow. Next factor was gonna be solubility of an, oh, you cannot see my, that is, okay. Solubility of the anesthetic in the tissues. So solubility as well in the blood is important, as well as the tissues is important. So there are relative solubility of anesthetic in the blood and the tissues, and determines the concentration in the tissues as well. Anesthetics with higher lipid solubility, for example, halotane, enter adipose tissue for hours and also leave it slowly. It means the induction and recovery are slow for those who have high lipid solubility. So it is an important thing to remember. And cerebral blood flow, obviously brain is the highly perfused organ, and general anesthetics are quickly delivered to the brain. So this can be the factor as well, which influences the induction and the recovery process. Now we talked about induction, and as well the reduction is just as important as the recovery. Recovery is just as important as induction. So elimination of anesthetic also should be a thing to consider. So when anesthetic administration is discontinued, gradients are reversed and the channel of absorption, for example pulmonary epithelium, becomes the channel of elimination. So inhaled anesthetics absorbed through the pulmonary epithelium and are eliminated through the channel of the absorption. Yeah. So now let's pause and drink some water. I advise you to do the same.